All right, thanks so much. So, Dr. Everhart, we're thrilled to have with us this evening. He's an instructor within the Division of General Medicine and Medical Sciences and the Department of Medicine at the Washington University School of Medicine in St. Louis. He received his PhD at the University of Minnesota and was previously a postdoctoral fellow at the Harvard MIT Center for Regulatory Science. He uses tools in economics in order to study how physicians make decisions and what drives the development and adoption of medical technologies. Tonight, he'll be talking about conflicts of interest in medical device development and utilization. Thanks so much for being here, Alex.
Thank you, Teresa, and to the Surgical Ethics Working Group for having me, and to all of you for being here today. I'll be talking about conflicts of interest in medical device development and utilization. So given the topic, I think it's appropriate that I share my disclosures. I've previously received grants from NIA, NBER, and ARC. I've received personal fees from the University of Southern California and the Digital Medicine Society, and I was employed as a research fellow by Medtronic during my PhD. So the reason we're here and talking about this is because I think most of us are aware of these high-profile cases where manufacturers are providing very obvious kickbacks to physicians, and that very clearly lead to patient harm. So this example, taken from a recent ProPublica article, found that VA healthcare workers were receiving things like steakhouse dinners, Apple Electronics, and NASCAR tickets from Medtronic, while the company's representatives really pushed physicians to use medical devices in a way that was clearly inappropriate. There was an investigative team that found certain cases where doctors were using 15 or more balloons, stents, catheters over the course of a single procedure. While this is certainly horrifying and a clear betrayal of patient trust, I also think this maybe, to be a little crude, isn't the most particularly interesting case study from an ethical perspective, because I'm guessing most of us in the audience think that this is unequivocally wrong. There's, very little ambiguity here. But the average physician, I think, has a relationship with industry that isn't quite so insidious. That can take a lot more benign forms. Often physicians will receive payments from industry for things like meals or reimbursement for training-related expenses. Surgeons will often develop relationships with medical device representatives under the expectation that these representatives are providing advice during surgical procedures that's going to hopefully improve clinical outcomes. And many physician inventors will help develop medical devices with the industry or provide consulting services during the development process that hopefully improves the quality of these devices. So these are some scenarios where there's contact with industry that might not be inherently problematic and potentially even beneficial. I think this potential for benefit that's really specific to the device industry is captured in this quote from an orthopedic surgeon. The surgeon says, "You can get information about a new cholesterol-lowering drug in the literature or at a society meeting. But to learn how to do a new spine procedure, you need industry to teach you how to use this new equipment they've developed." So in order to reconcile this tension between potential benefit and examples with obvious harms, we'll have two agenda items for the remainder of my talk. First, we're going to review the existing empirical literature of harms in the device industry using two main metrics. The first is examining the effect of medical device industry payments on physician decision-making. Do physicians who receive payments behave differently than physicians who don't receive payments? And second, independent of the actual decisions made by physicians, do patients perceive themselves as receiving lower quality of care based on the presence of potential conflicts of interest? Second, we'll spend some time talking about potential actions that providers or health systems can take to minimize conflicts of interest with the device industry, given what the empirical literature says about these potential harms. So first, when looking at the empirical literature on medical device industry payments, it's established that many physicians and most surgeons receive some form of a relatively small payment from the medical device industry, often for things like food or lodging associated with a conference presentation or a training session. So, for example, about 75% of neurosurgeons will receive an annual payment, a median payment of around $450, with similar statistics associated with orthopedic surgeons. However, despite the prevalence of this practice, there are very few studies that actually look at how industry payments affect physician decisions. And the main reason is that for the most part, we can't observe specific medical devices in most observational healthcare data sets. And I could do an entire talk on this particular bullet point about why that's problematic. But for now, I'll just say that's the reason why this literature is so small compared to the relatively large literature studying pharma industry payments. And particularly important is just the fact that there are a lack of studies showing the association between payments and decisions, but especially lacking are studies of the mechanisms between payments and decision making, really looking at how payments affect behavior, not just whether they affect behavior. And I'd like to convince you that this distinction about what are the mechanisms at play is really important for thinking about how we might manage conflicts of interest. It may be that payments work via a quid pro quo relationship, where a physician receives a payment, feels goodwill toward the manufacturer, and prefers their products. So then I think the action to be taken is pretty straightforward. We eliminate payments entirely, and that leads to improved clinical decision-making because physicians are no longer biased by these payments. However, it may also be that the dollars themselves are less important, but rather it's the relationship that happens either during these meals or just interactions between device representatives and physicians, where these physicians build relationships and feel an affinity toward manufacturers' products. This would suggest that simply eliminating payments, dollars changing hands, is going to be insufficient, that instead, more work needs to be done to fundamentally change the relationship between physicians and industry. And finally, it might be that payments are important for facilitating information. It might be that a cardiac surgeon who receives $300,000 a year doesn't really care that much about a meal. What's more important is that this physician is receiving information during training sessions that ultimately shape their behavior, and the payments are more incidental and not really consequential. So this would imply that limiting payments without any other corresponding actions might have negative effects on the quality of care if there's no way to otherwise provide this information or educational content. So with these potential mechanisms in mind, I'd like to walk through a couple of empirical case studies examining when and how payments affect physician decision-making. The first case study I'd like to introduce some of you to, I'm guessing many of you in the audience are familiar with this device, is Medtronic's Micra leadless pacemaker, a safer alternative to traditional transvenous pacemakers in certain clinical scenarios. Medtronic first introduced this product in 2016, and given that this was the first leadless pacemaker and it has a unique mode of application, physicians were required to attend a training put on by Medtronic that involved working in simulation models as well as animal and cadaver models before they could directly use this device in patients. This training program was reviewed by the FDA and was sort of incorporated into the clinical trial as well as the subsequent rollout in general clinical practice. So you might not be surprised, given that this training program was required as part of the use of Micra, payments from Medtronic related to leadless pacemakers were primarily reflective of travel to training centers. So this is the distribution of payments during the first few years of the introduction of leadless pacemakers. And these payments were almost entirely related to either travel and lodging or food and beverage, and relatively small. Medtronic is spending less than $1 million a year across these 4 years. One thing you'll notice is that the primary travel destination here is Minnesota, comprising over 50% of the payments that involve some sort of travel. And I'm from Minnesota, and so not to rag on my home state too much, but Minneapolis is generally not the destination you bring someone to woo them. Rather, Minnesota and Minneapolis is the location of Medtronic's training facilities. So overall, the descriptive evidence is suggesting that the vast majority of the payments during the initial introduction of leadless pacemakers are really just to get physicians out to these training sessions. So with that in mind, you might not be surprised that payments are associated with more use of leadless pacemakers. Each of these points represents the difference between physicians who received payments and those that didn't, relative to the timing of the payment. And so the main takeaway from this graph is that the difference between physicians who received payments and those that didn't increased over time, with on average, physicians who are receiving a payment having about a 4 percentage point increase in use of leadless pacemakers relative to those that didn't. But what's important to point out is that this increase in use was primarily concentrated in settings where micro was clearly indicated. So this graph on the left shows change in use after payment receipt, and payment was associated with about a 6 percentage point increase in use in settings where micro was clearly indicated, versus in settings where it's ambiguously indicated, it wasn't clear whether a leadless pacemaker or transvenous pacemaker would be more appropriate. Use generally increased at a much lower rate, about 2 percentage points after receiving payment. So overall, the evidence from leadless pacing seems to suggest that these payments are facilitating some sort of information transfer where physicians learn when to use the device and when to not use the device. In another study, there's a similar pattern looking at use of implantable cardiac defibrillators, where physicians who receive payments are more likely to specifically use defibrillators with cardiac resynchronization therapy among eligible patients. And we specifically note that in this particular graph, the relationship is more or less monotonic, where physicians who are receiving larger payments are more likely to use the technology when it's clinically appropriate. The same study also found that more payments lead to more appropriate medication at discharge for these patients receiving defibrillators, although the relationship is not monotonic and it's much smaller in magnitude. But again, suggesting that the payments, physicians who receive these payments are providing appropriate care, potentially more appropriate care than physicians that don't. Switching gears a little bit, it's also worth pointing out that many patients are generally not aware of potential conflicts of interest. So approximately 55% of US patients would say that they're generally aware that some physicians receive payments from industry. But if you ask them whether their specific physician, like their PCP, receives payments, less than 5% know whether their doctor receives payments. And this is information that's publicly available as part of the Affordable Care Act and the Physician Payments Sunshine Act. There's the publicly available Open Payments database where patients can look up whether the physician receives payments. But the passage of the Sunshine Act and the establishment of open payments did not change patients' awareness of whether or not their specific physicians were receiving payments. So overall, it looks like industry payments seem to have little effect on patients' perception of care, perhaps just generally due to the opacity of the healthcare system or a lack of interest in finding these things out. So it seems like this is not a top of mind issue for a lot of patients. So just to kind of summarize the literature overall, most surgeons receive relatively small payments from industry, and these payments often go hand in hand with training. Generally, the empirical literature suggests that payments lead to more use of a specific manufacturer's devices in settings when the devices are indicated. So to me, the main takeaway from the literature is that the evidence is sparse due to data limitations, but generally suggests these payments have at least some positive benefits. So proposals to completely avoid device industry relationships, conflicts of interest altogether, will need to provide some other mechanisms in order to provide this training that physicians would otherwise be receiving. So let's talk about some potential ways we can mitigate those conflicts of interest. We might simply ask hospitals or health systems to cover all of the expenses that the device industry is currently doing. So cover all those meals, cover all the training. And that seems potentially feasible. For the most part, in the status quo, these payments are relatively modest in size and not too frequent. It's, at least possible that physicians could instead pay for all these things out of pocket. But this brings back the question of what are the mechanisms at play here? Are these payments themselves driving behavior? Is it a quid pro quo relationship? Or do the interpersonal relationships that physicians have with industry, with their device representatives matter more? Others have proposed using a sort of repless model of physician training, where rather than rely on device industry representatives, health systems hire technicians to train and support their surgical staff, basically filling in the role previously played by device representatives. So this is, a potential policy response to industry conflicts of interest if we're worried about the relationships really mattering. But obviously, that's going to be a lot more expensive. You're hiring many new staff to cover, a function previously provided by industry. So to me, the bottom line is that providers are going to need to make up a difference in resources if existing conflicts of interest are deemed too problematic. So just wrapping up here, on average, device industry relationships appear to have a modest positive effect on clinical decision-making and don't seem to be on the mind of patients in terms of how they perceive quality. However, there are a lot of limitations to the existing research. There's simply a lack of studies due to just data availability. And also these empirical studies describe average effects kind of by definition. So some of you in the audience or healthcare systems might decide that these exceptional cases with clear harm may be enough to warrant systemic changes from providers, regardless of what's happening on average. So in order to mitigate these conflicts of interest, this will require providers or healthcare systems to step up and make financial investments, filling in the role previously provided by industry. That's all I have. I thank you for your time. If you don't get a chance to ask your question during Q&A, you can feel free to shoot me an email or find me on Twitter. I'll also share the references here, which you can take a screenshot or find during the YouTube video later. I thank you all for your time.
Thank you for an excellent talk, really thought-provoking. As your questions come up, especially, I saw a couple of good ones about some of the content and your thoughts. Can't wait to hear your answers to those questions later on. Please continue to post your questions in the Q&A so we can discuss them at the end. And with that, I will get ready to introduce our next speaker, Dr. Sabrina Sanchez. So Dr. Sanchez is a trauma and acute care surgeon here in Boston who is interested in care of vulnerable populations, including the elderly, seriously ill, and underserved and minority communities, specifically affected by social determinants of health. Her research focuses on different aspects of patient-centered care in these vulnerable populations and how to improve it. This includes investigating long-term outcomes and quality of life in trauma, emergency surgery, and critically ill surgical patients, assessing and addressing socially driven disparities in surgical care, driving quality efforts in the care of older adults, and promoting the use of shared decision-making in surgery. Academically, Dr. Sanchez is involved in both local and national initiatives to build a more diverse and inclusive surgical workforce as an integral part of providing just and equitable surgical care. Thank you so much for being here. She'll be talking about access to surgical care for the uninsured and underinsured. And Dr. Sanchez, when you're ready, just go ahead and come off of mute.
There we go. That's what I was looking for. Thank you, everybody, for the opportunity to talk to you tonight about access to surgical care for the un- and underinsured. I have no disclosures. In 1946, the WHO defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And they established healthcare as a human right by stating that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. They further specify that governments have a responsibility for the health of their peoples, which can be fulfilled only by the provision of adequate health and social measures. Now, healthcare is defined in the dictionary as the efforts made to maintain, restore, or promote someone's physical, mental, or emotional well-being. And there are a lot of things that go into that. Despite this broad definition, when people usually think of healthcare, they think of a combination of two things: access to care and quality of care. Insurance coverage, which is what we're going to spend the next 10 minutes or so talking about, is a contributor to this access to care. When looking at the big picture, however, it is important to keep in mind that insurance coverage makes a quite modest contribution to the overall health of a person. Insurance coverage affects access to care, which, along with quality of care, is what we usually refer to as healthcare, as I just mentioned. But that only contributes about 20% of what goes into a person's health. Beyond this, an individual's health behaviors and their social determinants of health, including their physical environment, education, employment status, and others, play a very significant role in an individual's health. That being said, I want to spend some time defining the types of access to care that a population can have as a contributor to someone's overall health. There are 4 types of access to care. With free and universal health care, every citizen receives care, and the care is free and publicly funded. In countries where care is not free but universal, at least 90% of citizens receive health care, but at least some of those citizens have to pay out of pocket for it. In places where care is neither free nor universal, people usually have to pay for care out of pocket, and the care is not widely available. Lastly, when care is free but not universal, people don't have to pay for care, but usually due to an underdeveloped healthcare system, not everybody can access care. In this map, you can see that in Canada, most of South America, most of Europe and Russia, there is free and universal health care. That is what's depicted in green. In some countries in Africa and a few in Asia, there is free but no universal health care. And that is depicted in countries in blue. In other African and some Middle Eastern countries and China, there is not free nor universal health care. Those are the countries in orange. Now, for the purpose of this talk moving forward, I'm going to focus on the one country that is not like any of the others, and that's the United States, where we have universal but not free healthcare. The evolution of healthcare coverage in the US has had a bit of an interesting trajectory. In 1912, Theodore Roosevelt was the first person to call for guaranteed healthcare coverage for all Americans. After that, and despite the WHO 1946 Constitution establishing health as a basic human right, nothing happened until 1965, at which time both Medicare for the elderly and disabled and Medicaid for the poor were established. In the 1970s, expansion of healthcare coverage shifted from trying to expand government programs to expanding the private market. And between then and 2014, that is all that happened, until the institution of the Affordable Care Act, which brought along with it the individual mandate, insurance exchanges, guaranteed coverage for pre-existing conditions, and Medicaid expansion. After that, in 2021, the Rescue Plan Act was passed and included expanded eligibility and federal financial support for individuals accessing coverage through the ACA, as well as further Medicaid expansion. Now, as a result of all of this, the number of uninsured people in the United States has significantly decreased. It's specific, if you look at the effect of the ACA and the ARP, there was a significant decrease over the last 20 years, with a high of 48.3 million uninsured people in the United States in 2010, and a most recent low of 25.3 million people in the first quarter of 2023. Over the last 3 years, in the United States, 6.3 million people have become insured, which is wonderful, but still leaves 25.3 million people without any health insurance. Now, who are these people? Well, they're mainly adults, since most children can become insured through Medicaid, but also the majority are low income, have at least one person that works in their home, are people of color, and they're also US citizens. And if you ask these people why they don't have insurance, it basically boils down to money. Almost 70% report that the care is not affordable. That's a reason why they don't have insurance. 26% report that they're not eligible for coverage. 23% report that they don't need it or want it. Then again, if it was free, why wouldn't you take advantage of it, right? 20% say that it's too confusing to obtain insurance coverage through the private market. 20% almost say that they cannot find a good plan that fits their needs. And 4% claim that they lost their job and that is the reason that they don't have insurance. Now, why is not having insurance bad for our health? Well, the main issue is that a lack of insurance leads to a decreased access to care. Excuse me. Compared to people with insurance, be it private or public, which is here in blue, patients that are not insured, which are the patients in green, have much higher rates of not seeing doctors, not having a usual source of care, postponing care due to cost, going without care at all because of the cost, and not getting prescriptions filled because of the cost. And what happens when people without insurance don't see doctors? Well, they get less preventative care, they get less screening, they get fewer diagnostic and therapeutic services, and they have more hospitalizations. They are also more likely to have a decline in their overall health over time, report poor health and physical functioning, have higher healthcare expenditures, and have a higher mortality risk. So overall, a lack of health insurance, either because it does not exist, as in countries where people have to pay out of pocket for healthcare, or because it is too expensive, as is the case in the United States, limits access to care. Unlimited access to care leads to worse health. Then from an ethical standpoint, the provision of free and universal healthcare becomes really an issue of justice. In fact, the most often cited argument for providing free and universal healthcare is protection of human rights, which is based on ethical theories about equity. The major philosophical theories about justice also generally accept that society must, in some way, provide for its least advantaged members. However, the right to health is what's called a positive right. That is something that must be provided by society to an individual. And this kind of positive right, when it comes to healthcare, brings with it two big challenges. The first is who is supposed to ensure its provision. And the second is where does health end as a right? How much and what are these providers supposed to provide to ensure that all individuals in a society can be healthy without going overboard? On the other hand, the ethical argument for the provision of healthcare in the United States is often weighed against the financial burden of its provision, the primacy of the free market, and political ideologies that feel very differently about the amount of social services that should be provided to the disadvantaged. So despite the clear ethical imperative to provide free and universal healthcare, and also the evidence from countries that provide it, that it leads to enhanced access to care, improved efficiency and equity, and overall better health outcomes, it is unlikely that these tensions that we currently have in the United States will be resolved anytime soon. So in this context, surgeons remain with a professional responsibility to advocate both for the health and well-being of their individual patients, but also policies that improve population health, including free and universal healthcare. I want to leave you with some final thoughts with regards to this, though. Healthcare coverage in the form of free and universal healthcare may be necessary to ensure health as a human right. And from an ethical standpoint, everybody should be entitled to it, regardless of race, religion, political belief, economic or social condition. However, it is not sufficient. This code puts it quite well. Even if it can be agreed that there's a right to a basic level of healthcare, this will not ensure good health, because even more fundamental justice problems arise within society that also require attention, such as needs for adequate nutrition, housing, and security, among others. Thus, I would argue that our professional responsibility goes beyond advocating for the health of our patients and the traditional policies we often think about that promote population health, but also includes advocating to address all the other social factors that contribute to disparities and thus injustice in surgical care. And with that, I'm looking forward to our discussion.
Thank you so much, Dr. Sanchez, for that great talk and giving us a lot to think about equity and justice in surgery. Just a reminder, keep those questions coming in the Q&A. And we are thrilled. I'll just have you, stop sharing your screen so we can have our next speaker, Dr. John Mayer, go ahead and share his screen and get ready to give us the last of 3 just fantastic talks. So Dr. Mayer, as many of you know, has authored over 450 peer-reviewed publications and 38 book chapters. He's on the faculty of the Boston Children's Hospital and Harvard Medical School for 38 years and is currently senior associate in cardiac surgery at Children's and professor of surgery at Harvard Medical School. He received his degrees from Yale and completed his general surgery and cardiothoracic training at the University of Minnesota, where he served from 1981 to 1984 in the USAF Medical Corps and led the initiation of an open heart surgery program at the USAF Medical Center. He joined the faculty in Boston Children's Hospital and Harvard Med School in 1984 and has carried out nearly 7,000 congenital heart operations. At Children's, he also served on the hospital board of trustees as chief medical officer, as president of the medical staff, and was one of the founders of the physician organization. His roles in national organizations include president of the STS and service as a board director for the American Board of Thoracic and American Board of Medical Specialties. He's been a member of the Congenital Heart Surgery Work Group since 2008 and the TSDA Ethics Committee since 2020. He was named a Distinguished Fellow of the American College of Surgeons of Cardiology in 2012 and received the STS Distinguished Service Award on 2 occasions. He's currently a member of the Health Policy Council and is immediate past chair of the task force on the Congenital Heart Surgery Database. He's a proud member of our Surgical Ethics Working Group and a graduate of the Fellowship in Bioethics at the Center for Bioethics. Today, Dr. Mayer will be talking about who makes the rules for patient care, the ethics of prior approval, and other health insurer policies. Thanks so much for being here. Okay, I believe we have Dr. Mayer ready. Let me see if we can hear him okay.
Okay, thank you very much. I'm sorry for all the technical problems. But in any event, I'm going to try to make a case for, the role of the profession somehow in trying to solve this problem. So I have enough conflicts to dispose. Next. So I think it's important to start the discussion with this notion about what is a profession, and in particular recognize that professions exist at society's pleasure, and that society uses a concept of a profession to organize the services that are consist mostly of healing the sick. Next. So everyone should understand, I hope, that there's really 2 simultaneous tracks that we go down. One is healing the sick, and the other is member of a profession. And these 2 lines of responsibilities, if you will, really go way back in history. So the notion of a healer goes all the way back to antiquity. Whereas this notion of a member of the profession is really something of somewhat more recent historical interest. But the important thing, dating from the time of Hippocrates, but also included in the professional lineage, if you will, is that the learned professions and on the healer side, as far back as Hippocrates, both emphasize the central role of a code of ethics. And as time has gone by, we have new technologies. You've already heard about that this evening. The ability to cure is far greater now than it was originally. And on the professional side, there actually has been legislation that has, in a sense, protected the professions. And other developments include the more close linkage to university and postgraduate education on the professional side. Next slide. So I've highlighted several roles and responsibilities of the profession. Justice Brandeis, as many of you know, was a lawyer, and put some of these together, and some other ones I've found in other places. But the important things are that profession is characterized by cherishing performance above personal reward, so-called intrinsic motivation. The profession has to establish its own standards and values and has codes of ethics, which are central, as I've tried to point out on the last slide. There's always this notion that we will always put our patients' interests above our own, whether it's caring in an earlier era for patients who had AIDS that we had no idea what was even the cause, to more recently throughout the COVID epidemic, where clearly many caregivers, essentially put their lives on the line to take care of sick patients. But there is another element to this role and responsibility of a profession, which has already been alluded to some extent, but perhaps stated a different way, that part of the responsibility of the profession is to try to make sure that what are ultimately finite medical resources are fairly distributed. And the reason I've highlighted this in a different color is to point out that sometimes that ethical responsibility actually can be in conflict with the other more patient-centered responsibilities. Next slide, please. So there is this interesting relationship between the profession and the society it serves. And this has been termed a social contract. And what really links the role of the physician and the role of the patient, and writ large, the role of society and the role of the profession, is that there are these mutual expectations and obligations. And what really holds this all together is professionalism, particularly on the part of the physicians. Next slide. So this social contract, again, requires us physicians to be healers, to provide altruistic service, to be moral, to have integrity, and to be honest. Those are highlighted by the asterisk, clearly ethical responsibilities, but we also have to have this simultaneous and sometimes in conflict, this promotion of the public good. And the reason this is a potential conflict is demonstrated as we go forward. So next slide. One last thing about professions, and that is that society only grants the prerogatives and privileges that are enjoyed by the profession to that profession, as long as it believes that society is acting in society's interest and not its own. And the key word here, I think, is in the second bullet, which is trust. And so when society loses trust in a profession, it no longer protects the profession from the forces of the market. Next. So the realities in this country, and most likely in most well-developed economies, but particularly in this country, is this ever-expanding share of the gross domestic product that is now being occupied by healthcare. And the trajectory doesn't really seem to be changing very much, although in the last year or two, maybe the public expenditures through the Medicare program have flattened out. But clearly there is this almost relentless march over the last 30 or 40 years in the increase in healthcare expenditures, number one, and in the percentage of the gross domestic product that is being consumed in healthcare expenditures. And so at some point, what we have to do in all well-developed economies is shown on the next slide, which, why don't we just skip this and go forward, is that we have to ration. And that's a sort of a, third rail to touch. You'll allow the subway analogy. No one ever wants to talk about this, but in fact, in all well-developed societies, we ration. And so in the United Kingdom, there are a couple of mechanisms that are involved, particularly the so-called NICE committee, which is the effectiveness committee for evaluation of effectiveness. The National Health Service basically controls almost all of the inpatient facilities in the UK, and they can effectively decide what things or what disease processes get treated. There was a period of time in the UK when if you were over 65 years of age, you were not offered hemodialysis if your kidneys failed. In Canada, there are different mechanisms, even though there's universal health care. Each of the institutions have budgets, and so you're limited to what you can provide as an institution and ultimately as a physician, because you have to stay under the budget. It used to be said that, if it was a bad time to be delivering your baby when it was at the end of the fiscal year, because the resources would be so limited. And the other way is to control the use of so-called high-tech or very expensive technologies. So MRI scanners, if you only buy a certain number, there are only so many MRI scans that you can do in a year. And, the waiting lists do exist in the Canadian system. So next slide. In the United States, we've got a whole variety of mechanisms, right, which include in some states like Massachusetts, there's a certificate of need process where the large expenditures like building a new hospital or other large capital expenditures, have to be approved by the state. But much of this rationing, if you will, occurs because so much of the healthcare is paid for by private insurers. And so there are a variety of really not very pleasant things that happen in this healthcare system. One is that the insurance companies can try to influence how patients use healthcare. So there are in this country frequently co-payments that you have to make. The insurance company would only cover 80% or 90% of the cost of the care, and the patient has to pay the rest. There's actually a big sociological experiment that was done 30 years ago called the RAND study that showed that this actually curbed the use of healthcare by the people who had to make a copay. Even if it turned out at the end of the year, it was revenue neutral. The other I don't want to be too pejorative, but the other game that insurance companies play is to engage in what's called adverse selection, so that that up until the Affordable Care Act was a way of keeping the high potential users of health care, people with chronic conditions or pre-existing conditions, could be denied getting health insurance. The other thing, and perhaps the focus of this discussion, is that there are a lot of things that are happening on the physician side that are frustrating and aggravating, to say the least, from the physician side. But I've listed a few here. This notion about getting prior approval, and if you don't get it, then the insurance company can deny payment after you've finished rendering the service, whether it's an operation or an office visit. They require that any specialist, in order to receive a patient, has to have a referral from their primary care physician. There was a big interest for many years in what was called capitation, where each physician in a practice that was caring for a panel of patients would receive a certain amount of money to cover all of their healthcare expenditures for a year. And that seemed like that would be an incentive for the physicians to reduce the amount of care or make it more efficient or effective. In fact, this never worked very well because no group could have a big enough panel of patients, and all you had to have was one patient that required an organ transplant, and your budget was blown for the next several years. And the final, again, I will argue is not been very effective way of trying to influence physician behavior is to engage in financial incentives, so the so-called pay for performance or pay for quality. The problem is this seems like a good idea in theory, but it falls apart when you get into discussions about what's quality, who defines it, what you actually measure. How do you compare, operating on somebody at age 80 with somebody who's age 40? How do you risk adjust for that? And in an attempt to avoid having to do that, then there was a lot of interest in what are called process measures. So, did you check everybody's immunization status? Did you check everyone's hemoglobin A1C to try to determine if there was diabetes? And that seemed all like good ideas, but in fact wound up driving up costs. Next slide. And I think when this has actually been studied, that this monetary rewards to try to motivate physician behavior actually frequently has the opposite effect. You may remember in one of the early slides, I talked a lot about intrinsic motivation and doing the right thing because it was the right thing to do. In fact, when you try to pay for reward that kind of behavior, you wind up actually preventing it or at least undercutting it. The results typically are temporary at best, and ultimately they have wound up backfiring in many situations. That's certainly true, and I have a quote in a discussion slide from Minister of Health in the UK, who tried to do this extensively and ultimately, found out that it was actually doing more harm than good. Next slide. And I would argue that pay for performance is inherently anti-professional. Because what do we do when we're in a profession? We share knowledge. We educate the competition that's coming in the next generation. I doubt that Microsoft would be sharing code with Apple, unless they could figure out a way to profit from it. The altruism aspect of the professional responsibilities. I outline in this little vignette here with a surgeon who is asked to go help one of his competitor colleagues, in another institution in the next town over or down the street. Why would he do that if it was straight market, if it was straight competition? And clearly there would be a significant problem with this responsibility to self-regulate because if we were getting paid for everything in one of these pay for performance deals, there's lots of incentives to game the system or to wind up needing a lot more regulatory oversight, which is then going to have equally deleterious effects. So clearly, these are problems with some of these economic incentives to try to influence, shall we say, how physicians take care of patients. Next. So here we have this problem, and the only thing that keeps the market forces at bay, whether it's the insurance companies or government regulators even, and I would lump that in with the market forces, is society ultimately must trust that the medical profession is going to act in society's interest. So what do we do? Next slide. So when we translate all of this to who makes the decisions and what principles should be used, I made this little schematic to suggest that, of our 4 classical bioethical responsibilities, 3 of them pretty easily all line up on the same side. So patient autonomy, beneficence, non-maleficence. Clearly, physicians and patients are aligned interests and clearly are ready and willing to have that be the way that the healthcare decisions get made. But there is that other responsibility in the profession, which is maybe encapsulated by justice or equal, equitable or wise distribution of scarce resources. Scarce because we can't spend all of the gross domestic product on healthcare. And then the question is, who makes that decision? Is that the government in a society such as the UK, or to maybe a lesser extent in Canada? Or do we rely, as happens in this country, there is some governmental impact, but also clearly the private payers, the insurers, are the surrogate for society. And they are to a significant extent largely unregulated. And it's really only the market that is driving their efforts to try to control healthcare. Next. So I don't have an answer to these questions. I think one can make the arguments on very sound ethical grounds that the patients and the physicians ought to make the decisions for patients. But then we have this other problem of our professional responsibility. We have society or surrogates make the rationing decisions, if you will. I think effectively that's what's happening. I would argue that ultimately the pathway that would be most effective would be that somehow we restore trust between the profession, particularly the medical profession, and society, and that we try in a collaborative way to allow this collaboration to try to solve both the societal problem of cost, but also to maintain our allegiance to the ethical principles of patient autonomy, beneficence, and non-maleficence. Next. So I apologize for not giving you any answers, but I can tell you in this U.S. society, we have been struggling with these problems for at least the entirety of my medical career. And I think in many ways, the problems are getting worse rather than getting better. But I do think that if we actually can talk about what the problem is, that is the problem of ever increasing cost, then perhaps we can find a way to reconcile what are potentially conflicting ethical principles. Thank you.
Thanks so much, Dr. Meyer, for a fantastic talk and really wrapping up and summarizing all of the issues that we are seeing in the, in our patient care space as we try to deliver equitable care. I'm going to kick some questions off here as soon as we hear from one of our fantastic fellows. Dr. Dane Panitz is a third-year general surgery resident at Johns Hopkins who's interested in congenital cardiac surgery. He spent the last year obtaining a fellowship in bioethics from the HMS Center of Bioethics and is currently a fellow in the fellowship in surgical ethics at the Washington University in St. Louis School of Medicine Center for Humanism and Ethics in Surgical Specialties. We're looking forward to hearing him reflect a little bit about what he's heard tonight as a burgeoning surgeon and surgeon ethicist and kicking off our question and answer period. Dane.
Yeah, good evening. Thank you, Dr. Williamson, and thank you to the Surgical Ethics Working Group for the opportunity to discuss these great talks. I don't have any slides to present and just want to quickly make a few comments and ask a couple questions that we may or may not get to because it looks like the Q&A is blowing up. But it was amusing to me to see the data that Dr. Everhart provided regarding both physician and patient perception of industry relationships, which I think I would have guessed to be true. It's also ironic that tonight I was invited to an industry-sponsored dinner for residents only that was not educationally motivated. So it's fortuitous that Dr. Everhart previously worked for a healthcare device company and Dr. Sanchez trained surgical residents. So my question maybe for both of them would be, so what advice do you have for surgical residents with regard to navigating relationships with industry representatives? Well, it seems like it could be a great thing for hospitals to bring intraoperative tech support in-house, or the so-called repless model that Dr. Everhart presented. And it would also be great for hospitals to cover the training expenses for physicians related to devices. I can't imagine this is going to happen very soon. So how can we build a patient-centered physician industry representative relationship. And then Dr. Sanchez's talk was a great reminder that healthcare also happens outside the hospital. And even if you do the best surgery, but they discharge the next day into a bad situation where they don't have reliable access to food, shelter, protection, medications, it can quickly erase the good that was done. I just came off this summer on our trauma emergency general surgery service, which sees some of the most vulnerable citizens in Baltimore. And I'm curious to know if Dr. Sanchez's program has any programs in place to support the uninsured and underinsured in her city. And then finally, I always love to hear Dr. Meyer talk about the role of the professions and how surgeons must self-regulate themselves by a code of ethics. It's hard for me to think of a better representative of our profession than Dr. Meyer, and I can only hope that I can emulate his professional career. My difficult question for him would be, how would you advise a young surgeon physician who's starting out and now has to worry about generating millions of RVUs, satisfying administration, juggling all sorts of hats that surgeons now have to wear, with doing the right thing because it's the right thing to do for the patient, but not always satisfying administration? So thank you for your time, and I look forward to the discussion.
Thanks so much for that great reflection. I'm sorry that we couldn't provide you with any free dinner this evening, Dane. So, I think it's a great time if we could just have all of our speakers rejoin us. That would be great. And we'll I think I'm gonna maybe start. We were talking a little bit about Dr. Everhart's presentation, and there's some good, like, sort of specific questions about these ideas of conflict of interest risks hidden within clinical practice guidelines, which patients and physicians alike may not be aware of. And so, a lot of the studies you talked about actually had a little bit of a positive decision-making effect. And I wonder if you could talk a little bit about the risk, be it perceived or real, in terms of conflict of interest when it comes to clinical practice guidelines.
Yeah, so I think there have been studies that have recently come out that sort of quantifies the extent that, like, these physicians who help write the guidelines, or there was another study that came out in the past couple months about what are these conflicts of interest for people who comment on, like, Medicare national coverage determinations. And so I think the takeaway from the empirical literature is just receiving a dollar from industry doesn't necessarily equate to a conflict of interest or, compromised decision making. And so I think it really, to me, it just comes down to the quality of evidence supporting those guidelines. And I think there's always, like, a lot of debate about, like, exactly how those guidelines are executed. So I think, like, if you, I don't know, are personally invested in figuring out, like, what are the origins of these guidelines, the data is publicly available. There's enough transparency where you could figure out who gets paid from where. But I feel like the evidence in those guidelines tend to speak for themselves, and you can evaluate based on that.
Yeah, absolutely. And I think probably there's a question kind of here about scale, right? And so, we have these, $450 that maybe I as a neurosurgeon get, or someone else, gets a dinner here or there. But what about these huge payments to institutions? They use the example of Allergan's payment of $51 million in 2022 to USC. And others. And, where is the line? Is there a line? Does it matter?
I can't speak to this. I don't know about the Allergan payment specifically. To me, I feel like for any of these questions, it ends up being that there is, like, some scenarios where, like, that's compromising quality, or I don't know, like the example I gave at the beginning, there were those Medtronic payments that were, like, very obviously leading to lower quality of care. And I sort of think what I tend to be drawn to is being able to monitor quality in a better way. I think there's like some serious data deficiencies about how we use medical devices and how we can track them and anything approximating real time. And so I think the solution for me is to get away from like, is this particular dollar spent like crossing a line or not, but more to like track outcomes, is care being delivered appropriately or not, and make the decisions based off that.
I think that makes a lot of sense. And then there's another question for you. I'm just going to keep you on the hot seat here and
Sure.
just keep going. About clinicians who actually, it's not receiving a payment, it's not consulting, but actually working for industry, right? So, I've read a couple articles recently about every physician needs a side gig. I think there's more and more pressure on US physicians, and burnout, et cetera, is driving folks into other directions beyond patient care. What do you make of those types of arrangements? Or other interests, I should say, are driving folks in those
Yeah, I think the question is kind of similar. Like you can imagine like a physician inventor or something who has their own side company and they've come up with their own product, and maybe they're using it inappropriately. There have been definitely cases of that where like physicians have been pushing their own product line, and we catch some of them and they're brought to court, and I'm sure there are other cases where it's not. But then there are also probably cases where a physician is involved in developing, the cutting edge, and it genuinely has clinical benefits. And so I think, to me, again, it just comes down to like making sure things are evidence supported and we can like track outcomes and closer to real time. Rather, I imagine there are there are obviously situations where being directly affiliated with a company is going to be problematic, but I can also think of counter stories where it's beneficial. So I think it's probably hard to define a rule, and we have to make our decisions based more on outcomes and like data actually tracking how devices are properly used, rather than thinking about what does the dollar do.
Yeah, I love that answer. And I think it's a nice bridge to some of the other things we've been thinking about when it comes to sort of accessibility of healthcare and what is like good healthcare. And I think I love that we put these talks together when it comes to, device relationships, and then our relationships with patients and our relationships with policy, because it really all overlaps, and the idea is to get a good outcome. And so I think, maybe this is a question for all three of you. This idea of principle of justice and equity, does a good society have to ensure good health for all citizens, or does it have to provide the means for good health for all citizens? Sabrina, Dr. Sanchez, you want to start?
Yeah, I think that's a really good question, and it's a very good point that ensuring something that has so much to do with other things that are not necessarily within society's control, right? Like, as I don't know if you remember from that diagram, but 30% of somebody's health does go back to the person's behaviors and their individual choices. So I guess ensure can be a bit of a strong word, but I think providing the ability to be healthy and the support for that to happen, it's definitely something that can be expected.
I'll maybe add that I think in practice, it's really hard to like think about a scenario where like the means to good health was provided as opposed to like actually the good health. Like, I don't know, like I think Medicaid programs in a lot of states or how about the state I'm in right now, Missouri, like, we have this coverage, but at the same time, it's like so difficult to get through all of this like bureaucratic process. So like, have we provided the means to good health or not? I feel like I think probably we have an obligation to do both, and like actually drawing like when are you satisfying one but not the other, is very difficult, if not impossible, in practice.
I will say though that when I say providing the means, it also has to be a reasonable way of providing that, right? And just offering insurance but making it so difficult for people to get it doesn't really cut in, right? Like you could say that there's so many options with the exchange right now for people in the United States to get insurance. Why does anybody go without? But you need to make reasonable efforts to provide it in such a way that people can actually get it. Um,
Dr. Meyer, did you have thoughts about that as well?
Really, I mean, I have several comments, and these are unsolvable problems, and at least simply, I think the one thing that I think is important is that someone famous once said, the physician's banner, now it's his keyboard or her keyboard, controls about 75% of the healthcare expenditures in the United States. So my own sense is that the physicians and the profession, have to be part of the solution. Because I hope I demonstrated well enough that, economic carrots and sticks, and to follow up on what Dr. Everhart was talking about, that's not the way to accomplish it. And what one really has to do is to appeal to that professional responsibility. Now, the problem for the professional is that you don't ever want to be in this position, and this was the position that capitation put physicians in, of choosing between your own economic well-being and the patient's health well-being, right? That's an untenable position. And I think that was the fundamental flaw in capitation. So then how else might the physicians actually be able to participate without becoming hopelessly conflicted in this problem of trying to wisely allocate healthcare resources? And for me, I think the pathway comes through what Dr. Everhart was alluding to, which is data. And so we, in our specialty in cardiothoracic surgery, we have, a large database. I mean, 6 or 7 million patient records in this database, all of whom patients have had cardiac or thoracic surgical operations. And so we know a lot about things that contribute to the risk of the operation, or, situations in which an operation would not be successful, or would be, I hesitate to use the word futile, but, would have a low likelihood of success. And it has been proposed and actually sort of got written into law, but never has gotten implemented. But I have argued for some time that if we knew what the resources that were being expended were, and we were able to combine that with the clinical outcomes, then we would really have a handle on trying to figure out what's effective care and what is cost-effective care. And I think that's still something that I would advocate for. And I think it gets the individual physician out of this conflict. But if we combine both clinical outcomes and economic or fiscal outcomes into a single database, now we could actually figure out what works and what doesn't, what's, wasteful or unnecessary care, or at least I think we would have a better shot at it. And that was kind of what I was alluding to when I was trying to advocate for this collaboration between the profession and society, because I do think, because we have at least a significant amount of control over how our healthcare expenditures are allocated and for what, I think it's at least worth exploring. That would be my argument.
I think that's a great argument. I think it ties right into what Dr. Everhart was talking about in terms of how we figure out these outcomes so that we can understand our relationships between carrot and stick if we're using them at all. I'm not going to let you off the hook with saying it's an unsolvable problem, and neither is our Q&A panel. So who's doing this work? Who is thinking about this? What examples do we have, either nationally or internationally, about, sort of developing systems in which we can provide as best possible, sort of equitable, effective care?
Well, as I said, this is something that has been part of my bio. Was, I was involved in government relations for the Society of Thoracic Surgeons for quite a while. And so there is legislation that's passed, it's the law, where if you're a qualified database, like the STS, adult cardiac database, congenital database, thoracic surgical database, then you're supposed to be able to get access to Medicare claims data. And so we can match. And, a given patient, we know all their clinical action, what went on with them. One could do this in a de-identified way. Then you would actually have a chance to, see what worked, see how much Medicare paid. And at least we would have the Medicare data. That would be the most important place to start, I think. And it would set a precedent for the private world too. I do think that, we haven't been able to get the agency, Medicare, CMS, to comply. This has been a source of major frustration, as you might imagine. But I think that it's one way, and the complaint is always, well, nobody else has got a database like this, so it's not fair. But on the other hand, maybe we could be the pilot study, or maybe we could be I think there are some opportunities here, and I may be being overly optimistic and, expecting too much of, those of us in our little corner of the medical world, but I think it's worth a try. And I think it's got at least as good a chance as, the economic carrot and stick approach, which is what's employed by the insurance companies. So, this has been going on for years now. I mean, the original legislation was passed several years ago, and we just haven't quite gotten there in terms of getting the agency to comply. And, we've got a few champions. There are actually a few, at least one or two cardiothoracic surgeons that are in the Congress now. So, we try to keep the pressure on, but we'll see. But I think, if you expand this out, you could think about keeping track of devices. And in fact, we do. We record all the serial numbers every time we put a pacemaker in, or a heart valve, or whatever, into a patient. We have that information. I mean, this is the information age. We should be able to figure out how to link this and still maintain patient privacy, and, not have, the wrong people know that, Dr. Williamson's got X piece of hardware in her or whatever. So I think there's some possibilities for this. Anyway, I would advocate for still continuing to pursue it.
Yeah, I think that's great. And it's nice to hear that optimism. And also just really what I've heard from all three of you is just a huge push for data and well-collected data to help sort of solve this problem. Before I move on to rationing questions, because there's a lot of questions about rationing, I did want to get to this question about providing an example of how society might lose trust in a profession and no longer protect it. And I was thinking about your example, Dr. Meyer, of when we as a profession and our patients are sort of, if we had potentially conflicting conflicting needs where it's, was best for the patient was not in the best interest for the provider or vice versa. And I think any of the three of you that wants to kind of just touch on that idea of losing trust in the profession as a whole, because I think it's an important question.
Well, I'll take a crack, I guess, at it. I do think, I think this isn't anybody's necessarily any single entity or segment of society's problem. I think, we have contributed to our own trouble, we in the medical profession. And, as they say, one bad apple spoils the whole, barrel or whatever. But, I think we as a profession haven't done such a great job of disciplining or self-discipline. I think in other countries, it's easier for this to happen. I think, in the UK or other places, the certifying boards are also basically licensure, as opposed to here in the United States, where that's the governmental function that determines licensure. The hospitals determine credentialing, and we certify our specialists through the certifying boards. So there's some advantages to not concentrating all the power and responsibility, but on the other hand, it allows for more what I would term rogue behavior on the part of physicians, and doesn't take too many times that you show up in the front page of the Boston Globe or elsewhere where the society starts losing trust and they wonder what's going on here in this medical profession. So I think that's, there's plenty to go around, and a lot of people have made, their whole careers and being critics of how medical care is developed. And, I've got a whole series of books on my shelf about, things that we haven't done very well as a medical profession. So it's on us as well as on other segments of society. But I do think that notion about trust being the glue that really sort of holds this relationship between physicians and patients, and between the profession and society together, is critical.
Agreed. And I think, we have just a minute left. I wish I could get to all of these amazing questions. I'll remind everyone to please keep the conversation going on social media, the HMS Center for Bioethics and hashtag HMS Bioethics, so we can keep this convo going. One last question I'll leave to Dr. Sanchez. Dr. Meyer brought up a lot of ideas about rationing, and there's at least 3 questions about justice and rationing, right? So can we ration based on behavior? Who's it going to affect? And is it going to affect minority communities or underserved communities more? How do we sort of maintain equity and fairness as we ration? I think these are really challenging ethical questions, and would love your comment.
Well, there's no easy answer, obviously. And these would not be ethical questions if there was an easy answer. I think you need to take them one by one and, find a balance. Because when it comes to justice and providing equitable care, what you need to try to do is make sure that nobody is getting, I can't think of a better word right now, sorry, but shafted for things that they can't control necessarily. And you could say that somebody that is smoking and drinking, or has a substance use disorder of some kind, well, they're choosing to do that. At the same time, what if this person has been in a situation their entire life where they've been unhoused, they haven't really had appropriate education, they haven't really had support from society in other ways, and that's what's driven them to those kinds of behaviors, either as a way to deal with mental illness that has not been treated, as a way to cope with potential lack of meaning in their lives from the position that they are in society. But then that makes it very difficult to say these people are choosing to do these things, so we should ration our care based on that. When what is our responsibility for that behavior even happening? I think it has to be very individualized. I do feel that to a certain extent, rationing of care does affect underserved communities more. And when I say underserved, it can be uninsured, it can be racial minorities, it can be disability, in any way that you can think of an underserved community. Because again, sometimes for reasons beyond those communities' control, some of the things that we usually think should be an individual's responsibility with regards to their care really become things that are beyond their responsibility. Just some thought.
No, it's fantastic thoughts and really thought-provoking, exciting work from all three of you. And thank you, Dana, as well, for sharing that perspective, which I hope, so many are thinking about and reflecting on whatever stage of career they're in terms of how we can take this information and move forward. I think there's a really cool comment in the Q&A about kind of refining our surgical ethics frameworks to encompass all the complexity of our current political system. And I think it really should be the work of this group and all the folks on this call to think about how we can best do that. So thank you again all for being here this evening and for as many of the sessions as you could make it to. And we look forward to seeing you at our next Harvard Surgical Ethics Conference.